Okay, now in the cerebellar lesion, we can say whether they have asked about the cerebral lesion or what are the applied aspect of the cerebellum or what is the clinical significance. First and foremost, the characteristic about the cerebellar lesion is the lesion will affect the same side, ipsilateral side, right. If the right cerebellar hemisphere has got some problem, then right side of the body will be affected and left side will affect the left side, right. That we know the reason for that thing. Okay, that is the important characteristic feature. Now, what can be the symptom or the cerebellar lesion? First and foremost is, like we know the functions, by knowing the functions going back, comparator function, damping action, all these things. The first and foremost we can say is ataxia. What is ataxia? Ataxia is the imbalance, right. It is due to incoordination, the motor abnormality that will happen due to the damage in the cerebellum. So, that damage in the cerebellum will affect the movement to happen, right, like the smooth movement to happen. So, there will be incoordination in that particular movement, like if you are walking, that gait, that walk, like how you are walking, that is called as the gait. So, that gait will get disturbed. Why? Because due to the lesion, the rate, range and force and direction of the movement is getting affected. So, this ataxia, if there is any problem in, like say, we can divide this cerebellar lesion depending on whether the vermis is getting affected or intermediate cerebellar or the lateral. Okay. So, we will not go into those detail like different region, we will just collectively know what are the cerebellar lesion effect. So, ataxia, in the case of the ataxia, if there is problem issue with rate, range and force of the contraction knowing, then that gait will not be normal, it will be like staggered gait or drunken gait we can call, that ataxia is happening, and that is mainly because of the lesion within the vermal or intermediate cerebellar hemisphere, right. That is the ataxia. The second one is dysmetria. Dysmetria or past pointing, like I gave you the example of picking up of the pen. If my comparator function and dampening function is acting properly, appropriately working, then those sequence of the movement that will, like say I have to move my hand up to this one, it will go up to this one, pick this pen up and bring it closer to my body, like say I have to pick and put it over here. So, my hand will go over there, pick it up and bring it over here, and that is done. But if there is an issue with the cerebellum, then it will not stop over there, that pendular movement, because inherently all the movements are pendular. So, it will go past point, instead of stopping over there, it might go over there, it might go over here. So, that dysmetria or past pointing is happening. The third one is, when this thing is happening, normally there should not be any hesitation, it should be very fine smooth movement. Hesitation tremor or intentional tremor will happen, in the case of the cerebellar lesion. What does it mean? It means first it might go overshoot. Second, when a person is about to reach to pick the thing, pick this one up, then there will be tremor like this way. Ideally, it should be go over there and pick the pen, bring it over here. If there is issue, it might be like initially at the resting condition, there might not be any tremor, it is in the resting condition, it is smooth. When you go and about to reach to the object, then there is tremor, that is the intentional tremor. And compare from basal ganglia. In the case of the basal ganglia, there was resting tremor, right, resting tremor, pill rolling tremor, like if you have, as if you have provided the pill and patient will keep on moving the fingers in like this way. Okay. So, that is the intention tremor, the third one. Now, what else will be there? The other thing will be dysdiadochokinesia, that we have covered, dysdiadocho or adiadochokinesia, like repetitive movement, the fast repetitive movement won't be able to be done. Okay. This diadochokinesia we can say. So, there will be disturbance in equilibrium, that will be in the form of the ataxia, then dysmetria, fast pointing, intentional tremor, then this diadochokinesia. Then there will be they say decomposition of movement, decomposition of movement. What does it mean? It means like there is a complex movement is about to happen. So, like say I have to move my hand, say this is, I do not know whether it is coming in the focus or not, like say in the arm, this is the arm and this is finger, those fingers are there. Okay. So, first you have to move this arm, then extend at the elbow joint, then flexion at the finger, like you have to reach to pick an object, then you will extend your arm out, there will be extension at the elbow joint, then for picking there will be flexion of the fingers, then you will flex the arm at the elbow joint. So, what does I mean to say? I mean to say like there are different component of a complex movement. First there should be extension of the arm at the shoulder joint, then elbow joint, then flexion at the finger. So, it is very smooth way, in a normal person it will happen in a very smooth coordinated way. If there is lesion within the cerebellum, these movement will get decomposition of the movement, it will be jerky kind of the movement, like first there will be extension at the shoulder, then second will happen the extension at the elbow joint, then there will be the flexion. So, it will be kind of a jerky, right. Similarly, not only in the performing the motor movement, also the motor movement with the vocal cord, like that is called as dysarthria, like dysarthria or decomposition of the movement or scanning dysarthria, we can call it scanning speech or scanning dysarthria, scanning speech, right. So, in the case of the scanning speech, what does it mean? Like say I have to speak this word, this diadochokinesia, right. I am able to say it in a smooth one go. If there is problem with the cerebellum, then I will divide this word into different syllables like diadochokinesia. Got it? A person who is having this issue with the cerebellum, that will pronounce this word by breaking it into different short syllables. Instead of saying this diadochokinesia, he or she will say this diadochokinesia. So, that is called as scanning speech or scanning dysarthria we can say. Okay, scanning dysarthria. Then there will be nystagmus. Nystagmus is, see, when you are looking at a particular object, say you are looking at this particular object, okay, your eyes are looking at this object, and all of a sudden you have to change from this object to this one, your gaze, you have to, that will happen very smoothly, right. Now, if there is issue with the cerebellum, then that movement, like you have to move your gaze from one point to the other point. Now, it should ideally it will be very smooth, it will go and end up over there. If there is issue with the cerebellum, it will move to and fro, it will past point the particular point, then again the brain will try to rectify it by bringing it back, then it will not stop over there, then again correction will be formed, correction will be done, and ultimately like say you can say like a pendulum movement it will happen, and ultimately it will end up at fixing the gaze at the desired point, right. So, this to and fro movement is called as nystagmus, to and fro movement in the case of the gaze, and say if this is the object and this is the component moving this much and this is. So, this component, the fast component or the longer component will decide which direction of the nystagmus is happening. So, that nystagmus will also happen in the case of the cerebellar lesion, right. So, these are the features that will happen, and yes, there will be hypotonia too. Hypotonia, like there is a resting tone of the muscles, right. That resting tone of the muscle is maintained via, see, the normally when there is no movement getting performed, inherently the Purkinje cell, they are stimulating at a particular speed, their rhythmic stimulation is happening and they are inhibiting the deep cerebellar nuclei. Deep cerebellar nuclei are also having inherent tendency of stimulation, they are getting inhibited. So, a little bit of transmission keep on coming downward on the spinal cord motor neurons, anterior horn cells, right, anterior horn cells, through which this tone is maintained. So, if there is issue with this cerebellum, then that resting tone will be abolished. So, that will end up in creating the hypotonia, and hypotonia means we can say there will be the flabby kind of the muscle we won't feel the tone of the muscle, atonia, flabby kind of the muscle. And depending on this, like say if there is a particular right sided cerebellar lesion or the left sided cerebellar lesion, I usually give very interesting example, say like if you are a 90s kid, you will know this thing. What is this? Like say in the 90s Bollywood movies, the villain will come, like I don't know you will get this idea or not, by live demonstration it would have been a very good example. Say this is the person, he is the boss or the villain, okay, villain, and there are all these chatru those sidekicks of this villain, and this villain has gone to the that protagonist character, the actor, and that actor doesn't recognize this villain. Now, what the villain will do? Villain won't introduce himself, his sidekicks will introduce, right. In that typical Bollywood Mumbai language, they will say, hey, tu bhai ko nahi janta. Then what the bhai will do at that time when he is getting introduced, intro is happening to this particular person, what is this villain doing? Villain will be like say just consider this is the right side of the villain and this is the left side, okay, and this right sided when this sidekick, they are on the right side of the villain. So, they are providing the intro of the villain, then villain will be looking toward this sidekick. So, the neck will be bent toward the right side and he will be lodged on the right side of the right lower limb, okay, right lower limb, and left arm, this it will be like say, hey, tu bhai ko nahi janta. So, the bhai, this villain will be looking on the right side, neck will be moved on the right side, right leg, and this left arm as well as left leg, it will be abducted and externally rotated, abducted and externally rotated. What does it mean? It means this particular villain, in a medical term you can say he has got the left cerebellar lesion. If there is a left cerebellar lesion, it means the left sided muscles, they are hypotonic. If there is left sided hypotonic of the neck and head control, like head is controlled, the position of the head is controlled by the neck musculature. So, if the neck musculature of the left sided is hypotonic, then the neck will move toward the right side. Similarly, the left leg and left upper limb, they are hypotonic. So, it will be abducted and like externally rotated, and what will happen to the weight of the body? Weight will of the body, entire body will be transferred to the right lower limb. So, he will be like standing on the right leg. So, that is how this hypotonia will happen. Okay. Now, all these functions we have covered, the ataxia, dysmetria, right, all these things, they can be tested or checked via these certain clinical test for the cerebellar dysfunction. We can say the clinical test for cerebellar dysfunction. What are these clinical tests? One is finger nose test. This one, these clinical tests that we will cover. Okay. When there happens any lesion then the lesion will be effect will be seen on the same side. That is the characteristic feature. The second characteristic feature is no sensory loss. It doesn't have anything to do with the sensation. And the third is no true motor paralysis. Like we will see in the next classes, coming classes, when there happens the issue with the corticospinal tract, there will be either the paralysis or the paresis. But in this one, there won't be any true motor paralysis. A bit of hypotonia will be there, but not true motor paralysis. Intellect won't be impaired. There won't be any impairing of the intellectual. Symptoms due to the entire symptoms, whatever the symptoms are happening, it will happen due to the disturbance of either the posture or the tone or the equilibrium or coordination of the voluntary movement. That is the characteristic feature of any kind of the lesion of the cerebellum, like what all the sign and symptom will be present. These things won't be there. Now, sign of the cerebellar lesion, these we have covered: scanning speech, dysarthria, intention tremor, nystagmus. Asthenia is asthenia means weakness, tiredness, ataxia, atonia or hypotonia, and this diadochokinesia, dysmetria, past pointing, decomposition of the movement, drunken gait because of this drunken gait or ataxia, pendular knee jerk. When we do the knee jerk, it won't be smooth, it will keep on moving to and fro like a pendulum. Yes, rebound phenomenon. And what type of rebound phenomenon I forgot to mention in those paper thing. Let me tell you, rebound phenomenon is like, say this is the arm and you have asked that person to flex this arm, okay, and you are providing a resistance. You are providing resistance. Against the resistance, this person has to flex the arm, and all of a sudden you remove this resistance. Now, what will happen in an ideal situation? When the person is flexing, the resistance was there, it will keep on forcing in the opposite direction of the resistance. As soon as the resistance is removed, it will stop, or that person will stop. The proper functioning cerebellum will stop the movement. But if there is cerebellar lesion, as soon as the resistance is removed, it will move this direction and then again, like it will be kind of a to and fro. That is called as a rebound phenomenon. Rebound phenomenon. So, that rebound phenomenon happens in cerebellar lesion. Okay. All these are sign in cerebellum. Yes, these are the cerebellar function test. Like all these function, the lesions are happening. How will you test it? For the upper limb, finger nose test, finger to finger test, writing, buttoning, diadochokinesia. For the lower limb, heel knee test and walk on a straight line. So, in the finger nose test, this is the person, the patient who is suffering from the cerebellar lesion. You will ask the subject to bring this index finger of the patient, first touch the doctor's index finger, then touch the nose, like continuous. That person won't be who is having cerebellar lesion won't be able to perform this movement smoothly. Either he will hesitate, he or she will, like there will be the intention tremor or past point that movement, that finger nose test, smooth coordination won't happen. Okay. Either the finger nose test or finger to finger test, like touch my finger and then your finger or the other arm. Okay, that finger to finger nose test is called as asynergia, means in coordination. That won't be synergy. Second is heel shin test for the lower limb. Like you will ask the patient to, like say this right limb, start from the heel to the shin, like either touch heel and then shin, or move it from this direction to this much. That person won't be able to perform this smoothly. Okay, smoothly. Asthenia means muscle weakness, slowness or easy fatigability. Then intention tremor is appearance of oscillatory movement during voluntary movement, absent at rest. You will ask the subject to write any word. Those words writing will be very jerky kind of a thing. That person won't be able to button or unbutton the shirt. Okay, button or unbutton the shirt, or while doing the buttoning or unbuttoning, there will be those tremor will be most pronounced, profound tremor will be there. at performing these fine movement. This diadochokinesia, inability to perform alternate movement rapidly, like you are the subject to pronation and supination of the arm, that person won't be able. Okay. Dysmetria, undershooting or overshooting, you are the subject to pick this object, but that person will end up either reaching over there or over here, won't go to the destined particular area. Okay. Decomposition, that split that we have covered, that is called as scanning or staccato speech due to dysarthria. Now, gait, walking on a straight line, you will ask the subject to walk on a straight line, that I discussed about the Romberg sign, right. Like you will ask the subject to walk in a straight line with the eyes open, Normally, a person will walk in a straight line with either the eyes open or the eyes closed, right. That is the normal thing. If the person is having an issue with dorsal column pathway, dorsal column carries the proprioception, right, vibration and position sense, then that person will be able to walk in a straight line with the open eyes. And if you ask the subject to close the eye and then ask him to walk in a straight line, that person won't be able to walk in a straight line. It means that person is suffering from dorsal column pathway lesion. Why? Because initially the person is suffering from the dorsal column lesion, still he is able to walk in a straight line with the eyes open, because when the eyes are open, that sensation is coming through the visual pathway, like how to walk and all. Okay. As soon as you cut that sensation pathway, the visual pathway, dorsal column is already affected. So, either through the visual pathway the sensation or through the dorsal column pathway sensation, if any one of them is intact, then that person will be able to walk straight, right. So, initially when the eyes are open, now the dorsal column is lesioned, but visual pathway is intact. So, the person is able to walk in straight line. As soon as you ask him to close the eyes, both are cut, then that gait won't be, that person won't be able to walk in a straight line. Now, what will happen in the case of the cerebellar lesion? In the case of the cerebellar lesion, now the person is having eyes open, won't be able to walk in a straight line. He will reel toward the side of the lesion, wide gate based and staggering lesion is there, right, because that ataxia is happening, drunken gait is happening, that position is not maintained. Okay. Now, the hypotonia will be there, reduction in the muscle tone, pendular knee jerk, rebound phenomenon, inability to put a brake on the movement, vertigo, that is the dizziness, and nystagmus, jerky movement of eyeball towards the side of the lesion, the fast component and slow component I would say. So, if the right side of the cerebellum is affected, that fast component of the nystagmus will be toward the right.